Yes.
Okay, good. So I'm going to talk a little about robotics, a very different topic, but robot is kind of the hot topic today in spine surgery. So I would really want to kind of talk to you a little bit about what is robotic spine surgery. Is this a fad, or this is really a revolution type of change, a real change in spine care? I really don't have anything in terms of disclosure. I'm currently not a consultant for any companies, but I am a board member on the North American Spine Society. Robotic surgery really it's a machine or mechanical device that operates a complex set of actions, right? So that's controlled by a computer, almost like human-like, and hopefully that it's going to improve our outcome overall. And so that's really kind of more of a definition of just basic robotic surgery. We do have a very good robot today called the Da Vinci. This is primarily used in more general surgery, urological surgery, and this comes with 4 working arms. And the surgeon sits basically in the operating room and operates this control, almost like a video game. And then the 4 arms will essentially reproduce the motion in a very precise manner. It's often used in urological surgery, but not quite yet in spine surgery. We have done certain type of prevertebral tumors using the Da Vinci, but that's not what a current spine robot is. Basically, if you think of robotics and spine surgery, it's mostly not really a robot, but it's more of a cobot. It's a computer-controlled robotic device, really designed to assist the surgeons. Kind of like you see here, a single arm kind of points to a certain spot, and that allows the surgeon to insert a device in a very precise manner in the patient. So robotic surgery is a computer-controlled robot based on CT for anatomical imaging input. The advantage is hopefully is that it improves accuracy and precision. So I'll talk a little bit about that later on in terms of comparison to what we currently have. Is it really any better? Improves angulations. Sometimes the angles can be very tough in spine surgery. So hopefully the robot can give you a very precise angulation and to certain inaccessible areas if you're trying to do it by freehand. It can certainly help with certain type of complex surgical tasks, especially in minimally invasive spine operations. It is very reproducible. And hopefully one of the things that we're really paying a lot of attention to is the overall radiation exposure, not only for the patient, but also for the staff that's in the operating room that's being exposed to radiation on a day in, day out basis. There are some limitations, and not, in my opinion, is not quite a game changer at this point. Some of the disadvantages, it is mostly surgeon dependent, so it's not a true robot, right? So it's not like you program this robotic person and it goes in there and does the operation for you. And I think we're all hoping that eventually a robot will be like that, but it currently is not. There's more of an assistant, it kind of helps you with certain tasks during the operation. It obviously lacks a tactile feel when you have a robotic arm, and you lose some of that touch. A lot of surgery, especially spine surgery, when we put these screws in, we move tissues around, take out tumors, move the nerves around. It's a lot of tactile feel, and that's the part I think for me I tend to lose that component. I think if I'm working with a robot, there are potential downsides and what's called skiving. So if you think you're in a certain position, but the screw skives, kind of like this pedicle screw is going right through the spinal canal, and sometimes you really can't tell because the robot, you think you're in the right position, but you're really not. It is very, very expensive today. Any of the robots that I'm going to show you, it's about $1 million range, right? So it's a very high capital cost for the hospital, especially now during COVID, when the hospitals aren't economically doing that well. It's very difficult for us to go and ask for a robot. There is definitely a learning curve. Sometimes the operation takes longer, which is okay. I think anything that's new technology-wise may take longer initially, but hopefully as we get better and the team gets better, the OR in terms of just the flow and how things work, that time can be cut down. So what's the advantage of robot versus humans? I think the robot is very, very good with 3D anatomy awareness. That's something we teach while residents and fellows always think in 3D, especially with the spine is very 3D. Thinking 3D makes a big difference in terms of understanding the overall anatomy. Maintain a certain, it's very good in terms of robots and maintaining a certain position angles, trying to hit those repetitive tasks at a certain angle. And that's what a robot does really, really well. It can make micro maneuvers. And you can't have multiple arms options, although currently in spine robots, are usually just one arm. Humans, definitely, you have that tactile feel, right? So a lot of times, just the feel, we know we're in the right position, we're not in the right position, how the tissue feels, and how that was put in a pedicle screw, how the pedicle screw in the bone is supposed to feel like. We're obviously very aware of dangerous anatomy, whereas robots currently are not. I think in the future, as software changes comes to play, if robots can be, we can use MRI-guided robotics and more soft tissue awareness, that could improve. And for, as a surgeon, the decision making is always always changing, right? So I always tell patients, we have our plan A going in, but certainly we have plan B, C, and D. In case something happens during the operating room, we have to make changes. This is where, I think we're much better compared to a robot in terms of making those changes. Our current applications, I think the downside with current versions of robots is primarily used for pedicle screw placement. And there are other ways that we use, we can put in very accurate pedicle screws that I'll touch upon later. Other potential uses will be like some type of spine biopsy, some type of tumor resection, like a prevertebral, or vertebroplasty or kyphoplasty, but that's primarily help direct that needle into the right spot. Not yet at this point is more advanced spinal decompression or any type of inner body fusion work. I think hopefully if we can get some of those other potential applications in line, I think robot potentially can have a lot more usefulness in the operating room. There are many, many different companies now that have their own version of robots. And so I'm just going to kind of show you a few of these. This is the Medtronic Mazer X. It's probably the oldest that's been out there. And the one thing I kind of want to show you is that all of these robots have a single working arm. So you have the Medtronic, you have the Zimmer Biomet, again, single working arm, kind of attached to a screen that we can see the spine, and that's based on prior CT images that can direct us to exactly where we want, let's say, for example, the pedicle screw to be. Here's BrainLab, again, a single arm approach. Globus, very similar, right? So you're looking at all these machines that are very, very similar, but then they have a lot of software differences. So there are certain advantages that Globus has that Medtronic doesn't, and vice versa. So you if you're in the market of getting a robot, you really got to really learn about each of these machines and see what they can and cannot do. And these are just a couple of other ones that's still out there. So I think one of the advantages of robotics is that you can actually pre-plan your surgery. Now this really comes into play when you're doing a scoliosis or spinal deformity or something that's minimally invasive. And here on the picture on the left kind of shows you kind of pre-plan these screws. So when you're, let's say, percutaneously putting a screw and rod in, you know that what you plan, the rod's going to connect, right? So it's going to be in a straight line. That you're not going to have one screw that's not in a good position that is going to make the connection very difficult. So I think that especially comes true, especially it's true with spinal deformity or abnormal anatomy in cancers and tumors where you don't have the normal anatomy. I think this is where pre-planning robotics becomes very, very helpful. The workflow is very similar to what's called intraoperative navigation. Robotic today, you can think of it as really a navigation device. It's very fancy. And it does really the same thing. And I'll kind of show you what a navigation device is. But that's kind of what we have with robots today, is more of a navigation. That's you can almost see it as a fancy navigation device. So here's kind of a quick video of the robot arm coming into play. So it basically, this arm is set up to exactly where you want that pedicle screw to be. And here's the surgeon doing his drilling, finding the pedicle. And so you drill right down that tube. That robot arm is held in place, and it basically stays there, right? It doesn't move. And this allows us a very precise drilling of that pedicle. You can actually probe it and make sure you're in the right place. And that arm basically stays in that one spot, right? So it doesn't move. And through that one port, you can do your drilling, you can do your tapping of the pedicle, and then you can insert your pedicle screw through all through in the same hole. So alternative to robots, in the old days, and even today, we use intraoperative fluoroscopy. There's certainly a lot of surgeons still uses a fluoroscopy. You have to be careful with radiation exposure, especially with the minimally invasive techniques, where a higher use of navigation or some type of image guidance is very important. So there could be a significant amount of radiation that's exposed. Intraoperative stereotactic navigation is what we have at USC. This is used for all minimally invasive fusion operations. It is very, very accurate. The question really is robot any better than current navigational device? And this is a good example of a navigation device. It's called the O-arm. It's basically intraoperative CT scan you can get, and it's connected to a screen. And then you can, like the robot, you can kind of direct where you want that screw to be, or in complicated anatomy where certain parts of the spine has been destroyed by tumors, so you can kind of get a sense through navigation. And we put the pedicle screws and different decompressions. You can actually use the navigation to kind of help guide you. So you can think of what's the difference really between a navigated device versus a robotic. It's kind of like driving today. Everybody has this GPS system, right? So every time I go somewhere and you get the Waze out, it tells you, well, turn right here, turn left here, but you're the one that's still driving. Now, I think the ultimate goal of a robotic in spine surgery is more similar to like an autopilot, right? So you can think of it, the three ways to put in pedicle screws. You have the fluoroscopy. Fluoroscopy is kind of like the old days when you actually whip out a map, right? So you're looking at the map. So I turn right. My wife would tell me turn right here, turn left there. Whereas navigation is like a GPS, and robotics is like an autopilot. It's kind of like the Tesla autopilot. You get in, you sit back, and the car will just take you from point A to point B. Now, we're not quite there, obviously, with robotic and spine, and I don't think the car is there either. So you still have to be careful, right? So anything we use in terms of even navigation, right? So we always teach that navigation should be a tool. You should learn how to put these screws in without a navigation. So in case the navigation breaks, you actually know how to put these screws in. And that's true for navigation, it's true for robotics. It should be as a tool to make things safer and not necessary to replace what we currently do. How about the accuracy of robotics? Paul Park published this review in 17 papers. The placement really ranges from anywhere from 85 to 100% accuracy, very similar to intraop navigation, and also to probably a little bit better than freehand technique or using fluoroscopy. Here's another publication that showed a 2.5% pedicle screw considered misplaced. So it's not perfect. I don't think anything is perfect, but I think overall it's good, both in terms of O-arm navigation as well as robotics. So I think overall the pedicle screw placement accuracy is not significantly better than with robots in terms of comparison to navigation or fluoroscopic guidance. So the question is, when will it become a game changer? At least for me, currently, I don't think it's a game changer yet. But I think at USC, we want to be in that forefront to kind of push this envelope in. There are things that I think can make it a game changer. I think things that robots can help us fundamentally look at an operation differently and change the operation differently. That's when I think it becomes a game changer. Here's some good examples I think that can help us with that. So here's a CT scan that shows somebody with OPLL, ossification of posterior longitudinal ligament. very severe compression of the spinal cord. If you were to decompress this from an anterior approach, it's a very, very dangerous operation in a sense, and because the spinal cord is tight. If the robot can tell us exactly how deep to go and actually help us with that component, I think that will make this operation much safer. But for me, that's a potential game changer. How about doing a different operation that we currently do in terms of fusions, allowing us to place these cages in a better position using robotics and tackling some difficult tumor cases with robotics. Those are potential game changers. But again, robotics should be really assistance, and it doesn't make it a bad surgeon good. You still have to have the basic fundamentals in terms of spine surgery, the goals and what we're trying to achieve. However, it will make a good surgeon better, hopefully. And I think that's what navigation did. And hopefully, I think I like to see robotics really take us beyond what navigation can do today. So today, there's not yet a clear demonstration of advantage of robotic spine surgery over traditional techniques. I think at this point, a lot of centers are using it more as a marketing tool. It does assist the surgeon, but cannot replace good judgment. I think the future, I'm very bullish about the robots. I think we're going to get there where robots will be a game changer for us. And I'm really looking forward to being hopefully one of the groups that kind of pushes the technology along so that we can make robotics part of all what we do in spine surgery to make spine surgery safer for patients overall. So